All right, so you requested a deep dive into ARDS and sent over some fascinating research. You're a medical professional, so we're going to skip those basic definitions and really get into the nuances of this complex condition in adults. Explore its clinical features, diagnostic challenges, and the potential complications.
That's right, going beyond the textbook here, exploring those gray areas that make ARDS so tricky to manage.
Perfect. Now, when we talk about the clinical presentation of ARDS, we know the usual suspects: progressive dyspnea, increasing oxygen requirements, and those alveolar infiltrates on imaging, all within a pretty tight time frame after that triggering event. But the research you sent over really highlights how these symptoms, while common, can be deceptively nonspecific.
Exactly, and that's where the challenge begins, right? Those initial symptoms can get tangled up with whatever triggered the ARDS in the first place. For example, a patient with sepsis-induced ARDS might already be experiencing shortness of breath and low oxygen saturation, just due to the infection itself.
So untangling the ARDS presentation from the underlying cause becomes a bit of a detective game.
Absolutely, and that's why a thorough understanding of the underlying etiology is so crucial in that diagnostic process. It's not just about recognizing the respiratory symptoms, but also about understanding their context.
The research also points out the importance of ruling out acute cardiogenic pulmonary edema early on. I'm guessing that's because it can mimic ARDS so closely.
Precisely, the clinical picture can be remarkably similar, which is why we rely on a combination of clinical judgment biomarkers like BNP or NT-proBNP and echocardiography to really differentiate between the two.
Now, BNP, that's a marker we often use to assess for heart failure, right? So we're looking for elevated levels to kind of steer us away from cardiac cause.
Yes and no. While elevated BNP levels can certainly raise suspicion for a cardiac etiology, it's not a foolproof test. We have to be cautious about overinterpreting a single lab value.
So it's more of a piece of the puzzle rather than a definitive answer.
Exactly. We need to consider BNP levels in conjunction with the clinical presentation. Other lab findings, imaging studies, echocardiography often plays a crucial role in confirming cardiac function and helping us rule out other potential cardiac causes.
Speaking of imaging, the research mentioned using transthoracic echocardiography when there's a suspicion of a heart issue. What are we looking for specifically in those cases?
We're looking for any signs of cardiac dysfunction, things like reduced ejection fraction, valvular abnormalities, or evidence of pericardial effusion. These findings can help us determine whether the patient's respiratory distress is primarily due to a cardiac problem or a pulmonary process.
But what happens when that initial evaluation, even with echo, doesn't give us a clear answer? What if we can't definitively rule out cardiac involvement or the clinical picture just seems atypical?
That's when further testing comes into play. The research you sent over highlights several additional tests that can be helpful in these situations. Repeat echocardiography might be warranted if the initial study was inconclusive, especially if the patient's condition changes.
And I see right heart catheterization mentioned as well. That's not a routine procedure in ARDS, is it?
No, not routinely. Right heart catheterization, or RHC, is reserved for specific scenarios where we need more detailed hemodynamic information. It allows us to directly measure pulmonary artery wedge pressure, which can help differentiate between cardiogenic and non-cardiogenic pulmonary edema.
So if the wedge pressure is elevated, it points towards the heart being the primary culprit.
Exactly. It suggests that the fluid buildup in the lungs is due to increased pressure in the heart's left ventricle rather than a primary lung problem.
Interesting. The research also touched on the role of bedside ultrasound. I've heard that's becoming increasingly popular in critical care settings.
It is bedside ultrasound is a quick and non-invasive way to assess the lungs at the bedside in the context of ARDS. It can help us distinguish between B lines, which are suggestive of ARDS, and A lines, which are more indicative of cardiogenic pulmonary edema.
So it's almost like having a portable X-ray right there at the bedside.
In a way, yes, it provides real-time visual information that can guide our diagnostic thinking.
And then there's bronchoscopy. When is that particularly helpful in the workup of ARDS?
Bronchoscopy is invaluable when the underlying cause of ARDS remains unclear, especially when we suspect an infectious etiology. It allows us to directly visualize the airways, obtain samples for microbiological testing, and even perform biopsies if needed.
So it's not just a diagnostic tool, but also a way to potentially identify the specific pathogen causing the problem.
Exactly. That's why bronchoscopy is often considered when the clinical picture suggests pneumonia, especially if initial cultures from sputum or endotracheal aspirate are negative.
And finally, we have lung biopsy. I'm guessing that's a last resort kind of procedure in ARDS.
Correct. Lung biopsy is reserved for very specific situations where other less invasive tests haven't provided a definitive diagnosis. It's typically considered when we suspect interstitial lung diseases, malignancy, or other rare conditions that can mimic ARDS.
So it sounds like we have a whole arsenal of diagnostic tools at our disposal, but choosing the right test at the right time requires careful clinical judgment.
Absolutely. We're not just ordering tests blindly. We're using our clinical expertise to tailor the diagnostic workup to each individual patient, considering their history presentation and the results of initial evaluations. It's all about piecing together the puzzle.
And speaking of the bigger picture, the research also mentioned a whole range of conditions that can mimic ARDS. It's not just about ruling out acute cardiogenic pulmonary edema, is it?
No, it's not. The differential diagnosis for ARDS is broad, and it's crucial to keep these other conditions in mind as we're evaluating patients.
Let's dive into some of those mimics in the next segment. We'll be back in a moment to explore the intricacies of differential diagnosis in ARDS.
Welcome back. We were just discussing how crucial it is to be aware of those conditions that can mimic ARDS. So let's delve deeper into that differential diagnosis.
It's interesting because the research you provided really emphasizes that diagnosing ARDS is often a process of elimination. We need to systematically rule out those mimics to arrive at the correct diagnosis.
That's a great point. It's not always a clear-cut case. We need to approach each patient with a healthy dose of skepticism, considering all the possibilities and carefully evaluating the evidence.
So let's start by talking about some of the most common conditions that can mimic ARDS. The research mentioned bilateral pneumonia as one of the key culprits. I imagine that's because it can also produce those characteristic bilateral opacities on imaging.
Absolutely. Bilateral pneumonia can present with a clinical picture very similar to ARDS dyspnea, hypoxemia, and diffuse infiltrates on chest X-ray.
So how do we differentiate between the two?
Well, the clinical history can be helpful. Pneumonia often presents with fever, cough, and sputum production, which might be less prominent in ARDS. However, there can be overlap, especially if the ARDS is triggered by an infection itself.
That makes sense. So we can't rely on symptoms alone.
Wow.
What about laboratory tests? Can those help us distinguish between pneumonia and ARDS?
They can provide clues, but not definitive answers, for instance. An elevated white blood cell count with a left shift might point towards an infectious process like pneumonia. However, patients with ARDS can also have elevated white blood cell counts due to the systemic inflammatory response.
So it's more about looking for patterns and considering the whole clinical picture rather than relying on a single test.
Exactly, and that's where microbiology comes into play. If we suspect pneumonia, we want to obtain sputum or endotracheal aspirate cultures to identify the causative organism.
And if those cultures are positive, it would strengthen the case for pneumonia rather than ARDS.
Exactly, but even then it's not always straightforward. Remember, some cases of ARDS are triggered by pneumonia, so a positive culture doesn't necessarily rule out ARDS.
It sounds like we're back to that detective work again. We have to consider all the pieces of the puzzle before arriving at a diagnosis.
That's right, and the puzzle gets even more complex when we consider other conditions that can mimic ARDS.
The research mentioned diffuse alveolar hemorrhage as one of those conditions.
Yes, diffuse alveolar hemorrhage is a serious condition where bleeding occurs into the air sacs of the lungs. It can present with sudden onset dyspnea, hypoxemia, and diffuse infiltrates on imaging, much like ARDS.
What are some clues that might point us towards diffuse alveolar hemorrhage rather than ARDS?
One key differentiating factor is the presence of hemoptysis, or coughing up blood. This is much more common in diffuse alveolar hemorrhage than in ARDS. Also, patients with diffuse alveolar hemorrhage often have a rapid decline in hemoglobin levels reflecting the ongoing bleeding.
So if a patient presents with acute respiratory distress and is coughing up blood, that's a red flag to consider diffuse alveolar hemorrhage.
Absolutely. It's not pathognomonic, but it certainly raises the suspicion we would need to confirm the diagnosis with further testing, such as bronchoscopy, which might reveal bloody lavage fluid.
The research also highlighted inflammatory and autoimmune conditions as potential mimics of ARDS. What are some examples of those?
Conditions like acute eosinophilic pneumonia, pulmonary vasculitis, and Goodpasture syndrome can all present with respiratory symptoms and imaging findings that overlap with ARDS.
And I imagine the diagnostic approach in these cases involves a combination of clinical suspicion, specific laboratory tests, and sometimes even tissue biopsy.
You're exactly right. We need to consider the patient's history. Look for specific autoantibodies in the blood and sometimes obtain a lung biopsy to confirm the diagnosis.
It seems like the more we dig into this, the more complex the differential diagnosis becomes.
It does, doesn't it? And we haven't even touched on other conditions like cryptogenic organizing pneumonia, acute interstitial pneumonia, acute exacerbations of idiopathic pulmonary fibrosis, and even things like pulmonary edema related to high altitude or toxic
It's
inhalation.
amazing how many different things can present with a similar clinical picture.
It is, and that's why it's so crucial to approach each case with a broad differential in mind carefully, considering all the possibilities before settling on a diagnosis.
The research you sent over also spent some time discussing the Berlin definition, which has been the gold standard for diagnosing ARDS for many years.
That's right. The Berlin definition provides a standardized framework for diagnosing ARDS, taking into account factors like the timing of symptoms, chest imaging findings, and the degree of oxygen impairment.
But I understand there's been a newer proposal, the global definition of ARDS, that's been gaining some traction. What prompted this shift, and how does it differ from the Berlin definition?
Well, you hit on a key point. One of the main drivers behind the global definition was the recognition that the Berlin criteria might be missing some cases of ARDS, particularly those with a more indolent onset or atypical features.
So the global definition aims to be more inclusive, capturing those subtle presentations that might have been missed before.
Exactly. For example, the global definition broadens the criteria for bilateral opacities on imaging, acknowledging that these opacities might not always be readily apparent on a chest X-ray, but might be visible on ultrasound or CT scan.
That makes sense. It seems like the global definition is trying to cast a wider net, so to speak, to catch those cases of ARDS that might otherwise slip through the cracks. But does it create any challenges in terms of overdiagnosing or creating confusion?
That's a valid concern. Some clinicians have argued that the broader criteria of the global definition might lead to overdiagnosis of ARDS potentially, including patients who wouldn't have met the stricter Berlin criteria.
So there's a bit of a debate within the medical community about the best approach to diagnosing ARDS.
There is, and that's healthy. It's important to have these discussions and critically evaluate the evidence as we refine our diagnostic criteria.
I'm curious about your thoughts on this as a clinician on the front lines. How has the emergence of the global definition impacted your approach to diagnosing ARDS?
Well, it's definitely made me more aware of the potential for atypical presentations. I'm more likely to consider ARDS in patients who might not have met the strict Berlin criteria, especially if they have other suggestive features or risk factors. I think it's encouraged me to think more broadly and keep an open mind when evaluating patients with acute respiratory distress.
So it's more about using these definitions as guidelines rather than rigid rules.
Exactly. Ultimately, clinical judgment still plays a crucial role in diagnosing ARDS. We need to use these definitions as tools to guide our thinking, but we can't let them replace our clinical reasoning and experience.
And imagine that experience becomes even more important when we're trying to tease out the subtleties of those ARDS mimics we were discussing earlier.
Absolutely. The more experience you have with ARDS and its mimics, the better you become at recognizing those subtle clues that might point you in the right direction.
Well, I think that's a great place to pause for now. We've covered a lot of ground in terms of differential diagnosis, from common mimics like bilateral pneumonia to more nuanced conditions like diffuse alveolar hemorrhage and autoimmune disorders. We've also delved into the evolving landscape of diagnostic criteria, exploring both the Berlin definition and the newer global definition of ARDS.
It's been a great discussion.
We'll pick up in the next segment by discussing the potential complications that can arise in ARDS, which are often intertwined with the underlying disease process and the challenges of managing critically ill patients. Welcome back to our deep dive into ARDS. We've talked about those complexities of presentation and diagnosis, and now it's time to kind of shift gears and discuss the potential complications. As we know, patients with ARDS are already in a precarious state, and complications can really significantly impact their recovery and those long-term outcomes.
Absolutely. And the complications we see in ARDS often stem from a combination of factors: the underlying disease process itself, the critical care environment, and the interventions we use to support these patients.
Let's start by talking about complications related to mechanical ventilation, which is often a life-saving intervention in ARDS, but not without its own set of risks.
Right. Mechanical ventilation, while essential for many ARDS patients, can sometimes lead to complications like barotrauma.
Essentially, injury to the lung tissue caused by the pressure from the ventilator.
Exactly. Ventilating stiff, non-compliant lungs often requires higher pressures, and those pressures can sometimes cause alveolar rupture or even pneumothorax.
And then there's the risk of infection, especially ventilator-associated pneumonia, or VAP?
VAP is a major concern in any patient on mechanical ventilation. The endotracheal tube acts as a potential pathway for bacteria to enter the lungs, and these infections can be challenging to treat, especially in patients who are already immunocompromised.
So preventing VAP is a top priority in ARDS management. What are some of the strategies you use to minimize that risk?
Well, we employ a multifaceted approach, often referred to as a VAP bundle. This includes meticulous hand hygiene, elevating the head of the bed to reduce aspiration, risk minimizing sedation whenever possible, to allow for earlier extubation and oral care with chlorhexidine.
Sounds like a combination of simple yet crucial interventions can make a big difference.
Absolutely, and it highlights the importance of a team-based approach to care nurses, respiratory therapists, physicians. Everyone plays a role in preventing VAP.
Moving beyond respiratory complications, the research you sent over also highlights the systemic challenges faced by ARDS patients, including things like delirium.
Delirium is a frequent issue in the ICU, and ARDS patients are particularly susceptible. It's that state of acute confusion and altered mental status that can be caused by hypoxia medications, sleep disturbances, and the stress of critical illness itself.
And I imagine delirium can have a significant impact on recovery, potentially prolonging hospital stays and increasing the risk of other complications.
It does. Managing delirium is often a challenge, but we focus on identifying and addressing reversible causes, minimizing unnecessary medications that might contribute to delirium, and promoting early mobilization to help reorient patients and improve their cognitive function.
Deep vein thrombosis, or DVT, is another concern in critically ill patients, including those with ARDS.
Yes, DVT is a risk for any patient who is immobilized, and ARDS patients are often bedridden for prolonged periods. We typically use prophylactic anticoagulation to prevent clot formation and reduce the risk of pulmonary embolism, a potentially life-threatening complication.
And GI bleeding, that's always a worry in the ICU setting.
It is. ARDS patients are prone to stress ulcers and other forms of GI bleeding, partly due to the physiological stress of their illness and partly due to medications like corticosteroids, which can increase the risk of GI bleeding.
So we're constantly balancing the benefits of these medications with their potential side effects.
Exactly. It's a delicate balance. We use the lowest effective doses of corticosteroids and other medications, and we monitor patients closely for any signs of GI bleeding.
Finally, let's talk about the nutritional challenges faced by ARDS patients. I know that adequate nutrition is crucial for healing and recovery, but it can be difficult to achieve in these critically ill patients.
It can be a real struggle. ARDS patients often have increased metabolic demands due to their illness, and they might have difficulty absorbing nutrients or tolerating enteral feeding.
So how do we address those nutritional needs?
Well, early nutritional support is key. We often start with enteral feeding, providing nutrition directly into the stomach or small intestine through a feeding tube. If the patient can't tolerate enteral feeding, we might need to resort to parenteral nutrition, which delivers nutrients intravenously.
It's another example of how managing ARDS requires a multidisciplinary approach involving not just pulmonologists and intensivists, but also nutritionists and other specialists.
Absolutely. It truly takes a village to care for these patients. We need to address not just their respiratory issues, but also their nutritional needs, their risk of complications, and their overall well-being.
As we wrap up this deep dive into ARDS, what's the key takeaway you want to leave our listeners with?
I think the most important message is that ARDS is a complex and dynamic condition with a wide range of potential complications. Early recognition, prompt diagnosis, and meticulous supportive care are crucial for improving outcomes in these critically ill patients.
And as research continues to evolve, so too. Well, our understanding and management of ARDS, it's a condition that demands our continued attention and a commitment to staying informed about the latest advances. And for our listener, we hope you found this exploration informative and insightful. Until next time, stay curious and keep learning. All right, so today we're going to do a deep dive on ARDS.
Acute respiratory distress syndrome?
That's right. And, we're talking to medical professionals here, so we don't have to, define everything. But
Right.
we do have this UpToDate article that I think is very interesting
Absolutely.
to help guide our deep dive today.
It's a fascinating topic and one that
Yeah.
I think is really relevant.
Yeah, so I was looking at this, and I didn't realize that ARDS was first, recognized in the 1960s.
Yeah, that's right. It was initially termed shock lung in Vietnam War veterans.
Interesting.
And it's amazing how much our understanding of this condition has evolved over time,
Yeah, for sure.
Yeah,
It's a significant number of patients, too, right?
absolutely. The incidence is about 86 cases per 100,000 person years.
Wow.
And in the United States, we see approximately 190,000 cases each year.
And 10 to 15% of ICU patients?
Absolutely.
develop ARDs.
And while some studies suggest the incidence might be decreasing, we need more data to confirm that trend.
Right, so we know it's a significant issue. What's actually happening in these lungs?
Well, in a healthy lung, there's a delicate balance of fluid movement. We know that the lungs maintain a small amount of interstitial fluid,
Right.
but ARDS disrupts this balance completely.
Almost like the lungs are drowning in fluid.
You could say that excess fluid starts leaking into the interstitial space in the alveoli,
Yeah.
and the Starling equation is critical to understanding this fluid shift.
So we're talking about retained intravascular protein,
Right.
tight junctions between those alveolar epithelial cells
Exactly.
and interstitial lymphatics.
Absolutely. Those are the three mechanisms that maintain an osmotic gradient and prevent alveolar edema in healthy lungs.
Yeah, so what happens when that goes awry?
Well, ARDS throws a wrench in the works. Inflammatory cytokines recruit neutrophils to the lungs, and these neutrophils release toxic mediators that further damage the lung tissue.
So then you get impaired gas exchange, decreased lung compliance,
Exactly.
and pulmonary hypertension.
All of which are bad news for the patient.
Bad.
And to complicate matters further, ARDS progresses through three distinct pathologic stages: exudative, proliferative, and fibrotic.
Right.
Each stage presents its own unique challenges.
So over 60 causes have been identified.
Yeah, that's right.
But we want to focus on the most common ones, like sepsis.
Absolutely. Sepsis is the most common cause, often presenting with fever, hypotension, leukocytosis, and a positive culture.
Aspiration, too.
You're right. About a third of patients who aspirate gastric contents develop ARDS.
Interesting.
The low pH in those gastric enzymes are incredibly damaging to the lungs.
And of course, pneumonia.
Of course, can be community-acquired or hospital-acquired, with a whole range of bacteria as the culprits.
And then severe trauma.
Absolutely. Bilateral lung contusion and fat embolism, both serious complications of trauma, can lead to ARDS.
And then massive transfusion.
More than 15 units of red blood cells significantly increases the risk.
And trailegally.
Exactly. Transfusion-related acute lung injury, which is distinct from massive transfusion.
Okay, and hematopoietic stem cell transplantation.
Those patients are at increased risk due to infection engraftment syndrome and the immunosuppressive medications they often require. It's a perfect storm for ARDS development.
And drugs and alcohol, too, right?
They certainly can. Aspirin opioids, certain chemotherapy drugs, and alcohol have all been implicated.
So many things can cause this.
It seems like it...
Inhaled toxins like
Yeah.
freebase cocaine, smoke inhalation.
Exactly. So we're seeing that ARDS can develop from a variety of insults, whether it's direct injury to the lungs or a systemic inflammatory response.
Is there anything that predicts which patients are most at risk?
Well, there's the Lung Injury Prediction Score, or LIPS.
Okay.
It helps identify patients who are unlikely to develop ARDS, considering factors like shock, aspiration, pneumonia, and recent surgery. But it's not a perfect predictor.
So still early stages.
Precisely.
Yeah.
And research into more accurate predictors using biomarkers is ongoing. That's one of the areas where we're hoping to see significant advancements in the future.
Wow, so many different ways to get to this.
Yeah, it seems like a lot of paths lead to the same destination:
Yeah.
acute respiratory distress.
It's very interesting.
It is a complex syndrome with a complex interplay of factors.
Not one size fits all.
Definitely not.
Okay, so we're going to talk about that in the next part
Sounds good.
of this deep dive.
All right.
Genetics. So that's adding like a whole other element.
It does. We're learning that certain genetic variations can actually predispose individuals to developing ARDS. For example, there are mutations in the gene that codes for surfactant protein B that have been linked to an increased risk of ARDS.
Surfactant protein B makes sense.
Right.
Yeah.
And we also know about the ACE gene, which codes for angiotensin-converting enzyme.
Right.
Variations in this gene, some of which are also associated with blood pressure regulation, seem to play a role in ARDS susceptibility as well.
So it's like another factor, right?
It is. It adds another layer to our understanding of risk factors. But it's important to remember that genetics isn't the whole story. All those other factors we discussed, sepsis, aspiration, trauma, those are still major players. It's likely a complex interplay of genetic predisposition and environmental triggers.
Right. So you could be predisposed, but
Yeah.
not necessarily get it.
Right.
So are there any biomarkers that could predict this better than the LPS score?
Well, there are some interesting leads. For instance, one study found that elevated levels of certain inflammatory markers in patients with sepsis were linked to a higher risk of developing ARDS. But we need more research before we can incorporate these biomarkers into clinical practice.
So still early stages,
Yeah.
but promising.
Yeah, I remember when we were learning about this, it seems so complicated.
It is a complex syndrome.
But going through this deep dive, it's like,
Right.
okay, I'm starting to understand this a little bit better.
You don't have to memorize every single detail of the pathophysiology.
Focus on the big picture, that cascade of inflammation, the fluid leakage, the impaired gas exchange. Those are the core concepts.
Right, so ARDS management
Yeah,
is not a one-size-fits-all approach.
definitely not. It requires a multifaceted strategy.
So supportive care, mechanical ventilation,
Absolutely.
fluid management.
They're all essential.
Essential.
Prone positioning.
But the key is individualization. We need to tailor treatment. All right, jumping right in, we're going deep on ventilator management for adults with ARDS.
Extracting the most relevant insights from the latest research.
And our primary source for this deep dive is the UpToDate article, Acute Respiratory Distress Syndrome, Ventilator Management Strategies for Adults.
Which was just updated January 25th, 2024.
So fresh off the press.
Hyping hot research.
And I know you're a medical professional, so.
You can skip the medical terminology 101 and really dive straight into those nuances.
Love that.
Yeah.
So let's start with that initial decision point. Invasive versus non-invasive ventilation.
You know that critical juncture in the ICU.
Absolutely.
So the research highlights that while intubation and mechanical ventilation are usually necessary for ARDS patients, non-invasive ventilation, NIV, does have a role to play in specific scenarios.
Interesting.
Yeah, and specifically they talk about high-flow nasal cannula and helmet-delivered NIV.
What are your thoughts on those? And were there any surprising findings there?
Well, you know, it's interesting because the type of mask used for NIV might actually influence outcomes.
Really?
Yeah.
That's fascinating.
So while NIV can be helpful initially, clinicians should have a low threshold for moving to invasive ventilation if needed.
Okay.
You know, it's about finding that balance between support and timely intervention.
Right. No one wants to delay intubation if it becomes necessary.
Exactly.
Absolutely. So let's talk about low tidal volume ventilation, LTV, kind of the gold standard for ARDS management.
Yep.
But, you know, the research suggests it might not be implemented as consistently as we would expect.
Yeah, you're right. One of the most striking takeaways is that despite the strong evidence supporting LTV's benefits, specifically its impact on reducing mortality, it's still underutilized in practice.
Wow.
Like, imagine the potential impact if we could close that gap.
Yeah, that's surprising to hear. It's not universally applied considering the evidence from studies like the ARDS Network Low Tidal Volume Study and that meta-analysis of 6 randomized trials. So what are some of the barriers to wider LTV adoption?
That's a great question.
Yeah.
And the research actually points to a lack of standardized protocols as a key factor.
Okay.
So having a clear written protocol outlining how to implement LTV can significantly improve compliance among medical teams.
So that's a really actionable insight right there.
Yeah.
For our listener, who's probably very familiar with the basics, let's kind of get into the practical application of LTV.
Okay.
What are some of the nuances of accurately calculating predicted body weight, PBW, and setting that initial tidal volume?
Well, the NHLBI ARDS network provides formulas and tables for calculating PBW, which is crucial because it forms the basis for setting that initial tidal volume. Remember, we're aiming for that sweet spot of 4 to 8 milliliters per kilogram of PBW.
And from there, we titrate to achieve a plateau pressure of 30 centimeters of water or less, correct?
Exactly. But it's not just about hitting a number. You'll want to closely monitor the patient's gas exchange and adjust the tidal volume based on the plateau pressure and any signs of patient ventilator dysynchrony.
Speaking of dysynchrony, I found that section particularly interesting.
Yeah.
It can manifest in a few ways, right? Like double triggering and reverse triggering.
You're absolutely right.
Yeah.
Double triggering occurs when the ventilator delivers an extra breath before the patient has fully exhaled.
Right.
And reverse triggering happens when the ventilator is triggered by the patient's exhalation rather than inhalation.
Oh, wow.
Both types can lead to increased work of breathing and discomfort for the patient. So recognizing and addressing them is key.
For our listener, what are some of the top strategies you find most effective in managing dysynchrony?
Well, it often starts with adjusting ventilator settings.
Okay.
So consider switching modes of ventilation tweaking the inspiratory to expiratory ratio, or even increasing sedation if the patient seems to be fighting the ventilator. In some cases, neuromuscular blockade might be necessary, but that's typically a last resort.
Right. So it's all about finding that balance between providing support and working with the patient's natural breathing efforts.
Exactly.
It's fascinating how much nuance there is in managing these cases.
Absolutely. And that brings us to the importance of ongoing monitoring and adjustments.
Yep.
The research really emphasizes this aspect.
The UpToDate article provides some really specific guidance on assessing gas exchange plateau pressure
Yeah.
and driving pressure, even outlining a protocol for adjusting tidal volume based on these parameters.
Right.
So it's clearly not a set it and forget it situation.
No, it's a dynamic process.
Right.
You need to stay vigilant and adjust those ventilator settings as the patient's condition changes.
Okay.
And this ties into the bigger picture of personalized medicine. We're not just treating ARDS.
Right.
We're treating an individual with ARDS.
And that personalized approach becomes even more critical when we start talking about refractory cases. Those patients who don't respond as expected to LTV.
Yeah.
The research dives into some fascinating options for those tougher situations.
Yeah.
So let's explore those.
Okay. That's where things get really interesting. You know, when LTV just isn't enough.
Right.
The research highlights that need for individualized treatment,
Okay.
taking into account a range of options based on each patient's unique situation.
Okay. So let's explore those options. The research mentions prone ventilation, ECMO recruitment maneuvers, and even pharmacological therapies. What are some of the key considerations when deciding which path to take?
Well, it's about weighing the potential benefits and risks of each option. For
Yeah.
instance, prone ventilation, which involves placing the patient face down,
Right.
has shown some promising results in improving oxygenation and even reducing mortality in severe ARDS.
Yeah.
But it requires careful monitoring and resources.
I remember when prone ventilation first gained traction.
Yeah.
Seemed kind of counterintuitive at the time. But the research is pretty compelling, particularly that 2013 study showing a significant mortality reduction. What about ECMO? When does that come into play?
Well, ECMO, or extracorporeal membrane oxygenation,
Right.
essentially acts as an artificial lung,
Okay.
allowing the patient's lungs to rest and recover.
Yeah.
It's a more invasive option reserved for the most critically ill patients, but it can be life-saving in those situations.
Wow. What about recruitment maneuvers?
Sure.
Those seem less invasive compared to something like ECMO.
Right.
What's their role in managing refractory ARDS?
Well, recruitment maneuvers involve applying brief periods of high pressure to open up collapsed alveoli, which can improve oxygenation,
Right.
while the evidence supporting their routine use isn't as strong as that for prone ventilation. They can be beneficial in select cases.
So it seems like the key is to really individualize the approach based on the patient's specific needs and that clinical picture. The research also touched on pharmacologic therapies, mentioning neuromuscular blockers, pulmonary vasodilators, and glucocorticoids. Is there a clear consensus on their use?
Not quite. The research acknowledges that the evidence supporting these therapies in ARDS is still somewhat limited,
Okay.
and they're generally considered adjunctive treatments.
Okay.
More research is needed to confirm their effectiveness and determine the optimal usage.
So it sounds like we need to proceed cautiously with pharmacological interventions and really focus on those patient-specific factors.
Exactly.
Now, the UpToDate article also specifically cautioned against a couple of strategies. Ultra-low tidal volume ventilation and high-frequency oscillatory ventilation.
Right.
Why is that?
Well, both of these strategies have shown limited or no benefit in clinical trials, and they might even carry potential risks.
Okay.
Ultra-low tidal volume ventilation, for instance, can lead to severe hypercapnia.
Right.
And high-frequency oscillatory ventilation just hasn't demonstrated a survival advantage.
So that's a good reminder that sometimes simpler is better.
Yeah.
Sticking with that well-established LTV protocol is often the safest and most effective approach for most ARDS patients. Now, before we wrap up, I'd love to touch on one more point. Open lung ventilation.
Sure.
Where does that fit into the overall management strategy?
Well, open lung ventilation, or OLV, combines low tidal volume ventilation with the recruitment maneuver.
Okay.
The idea is to maximize alveolar recruitment while minimizing the risk of overdistension.
Right.
It's a promising concept, but the research on its effectiveness is still mixed.
What are some of the key findings regarding OLV, and are there any potential downsides?
Well, some studies suggest that OLV can improve oxygenation, but the data on its impact on mortality is inconclusive.
Okay.
There are also some potential risks to consider, like barotrauma and pneumothorax,
Right.
so it's not a universal solution.
So it sounds like OLV is still an evolving area of research,
Yeah.
and its role in routine ARDS management isn't fully defined yet. This has been such a fascinating discussion covering everything from those foundational principles of LTV
Yeah.
to the intricacies of managing refractory cases.
Absolutely. It's been a great overview of the latest evidence and expert recommendations.
Hmm.
I think what stands out to me, and hopefully for our listener as well, is that while protocols and guidelines provide a solid foundation, the art of managing ARDS lies in tailoring those principles to the individual patient.
That's a great point. We have the guidelines, but it's our clinical judgment and experience that allow us to apply them effectively in each unique case. And that brings us to a crucial question for you, our listener.
Considering everything we've discussed, how does this information impact your approach to ventilator management?
What resonates with you? What will you do differently in your practice?
Yeah.
We've covered a lot of ground today,
Yeah.
but it all boils down to improving patient outcomes. And speaking of improving patient outcomes, something that really struck me in this research was the emphasis on addressing the underlying cause of ARDS. Seems obvious, but it's easy to get caught up in those ventilator settings and forget about the bigger picture.
It's a great reminder that we're not just treating lungs,
Yeah.
we're treating a whole person. Their medical history, their current situation, even their goals of care, all factor into that decision-making process.
Absolutely. And sometimes, it might mean recognizing that a patient's decline isn't solely due to ARDS,
Right.
but to another underlying issue that needs to be addressed.
Exactly. Maintaining a broad differential diagnosis and being willing to reassess if things aren't adding up is crucial.
It's fascinating how our thinking has evolved, even on something like permissive hypercapnia.
Yeah.
It wasn't that long ago we were striving to maintain normal CO2 levels in ARDS patients at all costs.
Right. It's a prime example of how scientific understanding and clinical practice evolve. We now recognize that permissive hypercapnia within certain limits can actually be beneficial in reducing lung injury.
It just goes to show that we should always be questioning our assumptions and staying open to new evidence. The research highlighted the progress we've made in managing ARDS, but it's clear there's still much to learn.
And that's what makes this field so exciting. There are always new questions to ask and new avenues to explore.
So for you, our listener, we want to leave you with this final thought. Considering the advancements in ventilation strategies, how do you see the management of ARDS evolving in the future?
What new innovations are on the horizon, and how will they shape the way we approach this complex condition?
Yeah, those were great questions.
We encourage you to ponder these questions as you continue to provide excellent care for your patients.
As always, we've included links to the full UpToDate article and other resources in the show notes. Thanks for joining us for this deep dive into ARDS management. Hey everyone, welcome to our deep dive into UpToDate's guidance on ARDS management in adults. We know you're busy medical professionals, so let's skip the basic stuff and jump right into the meat of it.
Absolutely. Straight to the good stuff.
Perfect.
Yeah.
So UpToDate is really pushing for this conservative fluid management in ARDS, even in patients who aren't obviously overloaded with fluid. It seems counterintuitive at first.
Yeah, it might seem that way initially, but the reasoning behind it is really interesting. When you consider the pathophysiology of ARDS, the blood vessels are kind of leaky, so the lungs are already prone to edema, and their ability to handle fluid is just not what it normally is. So being careful with fluids is super important.
So it's about that balancing act, right? Making sure there's enough blood flow, but also not overwhelming the lungs.
Exactly. UpToDate wants us to shoot for a neutral or even slightly negative fluid balance. They're even talking about specific numbers like a central venous pressure under 4 millimeters of mercury, or a pulmonary artery occlusion pressure of less than 8.
Those are pretty specific targets. How do we actually achieve that in practice?
Well, often it means using diuretics to help pull off some fluid. It's about being more proactive with fluid management. And of course, the type of fluid we use for resuscitation matters. Balanced salt solutions are usually preferred, but it really comes down to the individual patient's needs.
Personalized medicine in action. UpToDate also mentions point-of-care ultrasound is becoming more important in managing ARDS. Are you seeing that more and more?
Oh yeah, for sure. Point-of-care ultrasound is a game changer. We can actually see what's happening with fluid in real time, right there at the bedside. It helps us fine-tune decisions about giving fluids or using diuretics.
It's like having a window into the lungs. To back up this conservative approach, UpToDate highlights a study with 1,000 ARDS patients. They were randomly assigned to either a conservative or liberal fluid strategy. What were the results?
So in the conservative group, they aimed for a CVP between 4 to 8, or a PaOP of 8. And in the liberal group, they were shooting for a CVP of 10 to 14, or a PaP between 14 and 18. What's interesting is there was no big difference in mortality between the two groups.
So even though the fluid strategies were different, the outcomes were pretty much the same.
Yeah, but here's the thing. The conservative group consistently hit their CVP and PaOP targets. So it looks like there could be some advantage to having that tighter control over fluid balance. It might be too early to say for sure, but it definitely leans towards that conservative approach.
Speaking of needing more research, UpToDate mentions some retrospective data suggesting a potential benefit with conservative fluids, especially in certain subgroups worth exploring further.
Absolutely. Retrospective data can give us some ideas for where to go next, but we need more solid evidence from well-designed studies to really confirm these findings. Definitely an area that needs more attention. Let's switch gears for a moment and talk about neuromuscular blockers. Paralytics, as they're sometimes called UpToDate, doesn't routinely recommend them for ARDS.
Makes sense. We all know they can have some pretty serious side effects. I'm guessing that plays into the decision-making.
Yeah, the decision to use neuromuscular blockers or NMBs comes down to risks versus benefits. Right now, the evidence just isn't strong enough to say that the benefits clearly outweigh the potential harm.
So when would you actually consider using NMBs in ARDS?
UpToDate suggests reserving them for those really tough cases, severe hypoxemia that just won't respond to our usual ventilation and sedation. Basically, when we've tried everything else, and the benefits might outweigh the risks in that extreme situation.
Okay, that clarifies things. What about inhaled pulmonary vasodilators? UpToDate mentions those as well. What's their place in managing ARDs?
Inhaled pulmonary vasodilators, they're an interesting option. They're used when we're dealing with severe ARDS and hypoxemia that isn't improving with our standard treatments, like ventilation and sedation. The goal is to get more oxygen into the blood by dilating the blood vessels in the parts of the lung that are working well.
So improving ventilation perfusion matching.
Exactly. We're trying to get the blood flowing to the areas where it can pick up the most oxygen.
What are some of the common inhaled vasodilators?
You'll see inhaled nitric oxide epoprostenol and inhaled prostacyclin used pretty frequently. The choice often comes down to what's available at your hospital and the cost of each option.
Practical considerations always factor in. UpToDate also mentions that we need to figure out if these vasodilators are working pretty quickly.
Right? We usually look for signs of improvement in oxygen levels within the first 24 hours of starting treatment. If we don't see any improvement by then, it's usually best to stop the vasodilator and try something else.
Data-driven decision-making.
Yeah.
Let's move on to glucocorticoids. UpToDate says they might be helpful in a few specific situations. Can you walk us through those?
Sure. Firstly, they recommend considering glucocorticoids when ARDS happens in patients who already have conditions that benefit from systemic glucocorticoid therapy, things like refractory septic shock, COVID-19, or certain pneumonias. Basically, we're using the knowledge we already have about how glucocorticoids can help in those specific conditions.
Taking advantage of existing data.
Exactly. The second scenario is when a patient has early, moderate to severe non-COVID-19 ARDs, and they're not getting better with our usual treatments. But timing is key here.
You mean starting glucocorticoids early in the disease course?
Yes. UpToDate recommends starting them within 14 days of when the ARDS started, for the best chance of a positive outcome.
Early intervention is critical. What about the specific glucocorticoid regimens? And any preferences there?
While the perfect dose and how long to give them are still being studied, dexamethasone and methylprednisolone are the usual suspects. And we do have a few randomized trials showing potential benefits of giving glucocorticoids early on in the right patients.
Sounds promising. Yeah. Let's shift gears a bit and talk about the role of supportive care in ARDS management. UpToDate really stresses how important that is.
It's absolutely foundational. Supportive care is all about keeping the patient as comfortable as possible, preventing complications, and making sure their organs are supported. UpToDate doesn't go into every little detail here, but they do emphasize that it's a vital part of the overall care plan.
That makes sense. Especially in ARDS where patients are so sick. It must be pretty challenging to provide good supportive care.
You're right. These patients often need intensive monitoring and interventions to manage a whole range of potential complications. But don't worry, we'll dig into some of the specifics of supportive care in the next part of our deep dive.
Sounds good. We've covered a lot of ground in this first part, but there's still so much more to explore. We'll be back soon with part 2, so stay tuned.
Welcome back! Ready to dive a little deeper into the world of ARDS management?
Definitely. In that first part, we really focused on conservative fluid management. It's kind of a new way of thinking about fluids in these patients, right?
It is a paradigm shift. And for good reason. That old idea of just pumping them full of fluids, it's being challenged by research that shows being more careful with fluids actually leads to better results. Remember those lungs in ARDS? They're really sensitive to fluid buildup.
It's all about finding that sweet spot, right? Making sure there's enough blood flow without overloading the lungs.
Precisely. And the benefits might go even beyond just preventing pulmonary edema. There's some research suggesting conservative fluid management might even be good for cognitive function in ARDS survivors.
That's incredible. It really shows how even something as simple as adjusting fluids can have a ripple effect. Now let's circle back to those neuromuscular blockers. We talked about them a little bit before, but I want to explore their use in ARDS a bit more.
Sure. As we discussed, UpToDate isn't a fan of routinely using neuromuscular blockers or NMBs. The research on them is kind of mixed. Some studies show they might lower mortality, but others show a higher risk of complications.
So it's a real tightrope walk, weighing the good against the bad. Are there any specific situations where you'd think about using NMBs besides that severe hypoxemia we talked about?
Well, there is one scenario where they might be especially useful, making mechanical ventilation work better, especially in patients with severe ARDS. Their lungs can be really stiff and hard to ventilate. NMBs can help synchronize the patient's breathing with the ventilator, potentially improving oxygenation.
So it's about making the ventilator work as efficiently as possible in these really tough cases.
Exactly. But again, the decision to use NMBs should always be individualized, taking each patient's specific situation into account and weighing the potential benefits against the potential downsides. Now let's shift our attention back to those inhaled pulmonary vasodilators.
Oh, yeah. Those are the ones that redistribute blood flow to the parts of the lungs that are better ventilated, right? I'm really finding this concept interesting.
Me too. It's like they're little traffic cops in the lungs, directing blood flow to where it can get the most oxygen. UpToDate mentions inhaled nitric oxide, epoprostenol, and inhaled prostacyclin as possibilities.
But choosing the right one can be tricky. What factors go into that decision?
You're right. It's not always clear-cut. Practical things often play a big role. What's available at the hospital, the cost of each option. Some centers might prefer prostacyclin because it's less expensive and easier to give than nitric oxide.
It's all about making smart choices based on what you have and what the patient needs. Once you've started an inhaled pulmonary vasodilator, how do you know if it's actually working?
Close monitoring is key. We usually look for improvements in those oxygen levels within the first 24 hours of starting treatment. If there's no significant improvement by then, it's usually time to stop the vasodilator and think about other options.
Using the data to guide your decisions sounds like a similar approach applies to glucocorticoids in ARDS.
Glucocorticoids. They're an interesting topic in ARDS. They can potentially calm down that inflammation that's damaging the lungs. But there's been a lot of back and forth about whether they really help.
The evidence hasn't always been super clear. So when does UpToDate think we should consider glucocorticoids in ARDS?
They outline two main situations. First, like we talked about before, when ARDS happens in someone who already has a condition that benefits from systemic glucocorticoids, like refractory septic shock, COVID-19, certain pneumonias. We're basically building on what we already know about how glucocorticoids work in those situations.
Leveraging that existing evidence.
Exactly. The second scenario is when a patient has early, moderate to severe non-COVID-19 ARDS, and they're not improving with our standard treatments. But timing is everything here.
You mean starting the glucocorticoids early on?
Right. UpToDate recommends starting them within 14 days of when the ARDS first showed up. If we wait too long, it doesn't seem to be as effective.
So there's a window of opportunity. What about specific glucocorticoid regimens?
The ideal dose and how long to give them are still being debated. But dexamethasone and methylprednisolone are the go-to options, and we do have some good trials showing some benefits of using them early on in the right patients.
So there's still more to learn, but it's looking promising. Let's turn our focus now to that sometimes forgotten but super important part of ARDS management, supportive care.
It's the foundation supportive care. It's all about keeping the patient comfortable, preventing complications, and making sure their organs are functioning as well as possible. UpToDate keeps it pretty high level here, but they stress that it's a crucial part of taking care of these patients.
It's easy to get caught up in the fancy stuff, like ventilator settings and medications, but supportive care can make just as big a difference, maybe even bigger in the long run.
Couldn't agree more. Things like managing pain effectively, choosing the right sedation strategy, providing good nutrition, and preventing infections, these things can have a major impact on how well a patient recovers.
It's all about the details. Now, I want to dig into a few specific aspects of supportive care that UpToDate mentions. They talk about preventing venous thromboembolism, or VTE. Why is that such a big deal in ARDS?
Great question. These patients are more likely to get blood clots, especially deep vein thrombosis and pulmonary embolism for a couple of reasons. They're often stuck in bed because they're on a ventilator and sedated, and the inflammation that comes with ARDS makes their blood more likely to clot.
So it's about being aware of that risk and taking steps to prevent it.
Exactly. UpToDate recommends a multi-pronged approach. Using blood thinners, mechanical methods like compression stockings or those inflatable leg wraps and getting them moving as soon as it's safe.
A comprehensive strategy for a serious risk. What about stress ulcer prophylaxis? Why is that so important in ARDS?
Stress ulcers can develop in really sick patients, including those with ARDS. It's a combination of things. The stress of being so sick decreased blood flow to the stomach lining, and certain medications like corticosteroids can all contribute.
So stress ulcer prophylaxis is all about protecting the stomach.
You got it. UpToDate recommends being proactive, using medications that reduce stomach acid or protect the stomach lining to lower the risk of these ulcers forming.
Another example of how a small intervention can prevent a big problem. What about venous access in ARDS? What are the things to consider when deciding on the right type of venous access?
Well, UpToDate points out that we often need central venous access in ARDS to give medications fluids and take blood samples. But central lines come with their own risks like infection and other complications.
So there's a balancing act again, benefits versus risks.
Right. We shouldn't just put in a central line without thinking it through. We need to consider each patient's individual needs and how long we think they'll need treatment to decide if the benefits outweigh the risks. And if we do put one in, taking good care of, it is essential.
UpToDate really emphasizes using proper techniques, keeping the dressing sterile, and checking regularly for signs of infection.
Absolutely. Every step, even the seemingly routine ones, needs to be done with extra care when we're dealing with critically ill patients. Let's move on to another important part of supportive care, fever control. Why is managing fever so critical in ARDS?
Well, fever makes the body's metabolism work harder, which means it needs more oxygen. And that's a problem when the lungs are already struggling to deliver enough oxygen.
Right, it's a double whammy. Not only does fever increase the demand for oxygen, but it also makes it harder for the lungs to supply that oxygen. So we need to figure out what's causing the fever and treat it while also taking steps to bring the temperature down.
Like using medications, cooling blankets, or other ways to control temperature.
Exactly. And lastly, let's touch on blood transfusions in ARDS. When might someone with ARDS need a transfusion?
Well, there are a few reasons. They might need it to correct anemia, boost their oxygen carrying capacity, or fix clotting problems that can happen in critical illness.
You're right. But like all decisions in ARDS, we need to make transfusion decisions on a case-by-case basis, looking at the patient's overall condition, their lab results, and the potential risks and benefits of giving them blood.
It's about using blood wisely, only when it's really necessary.
That's it. And that wraps up part 2 of our deep dive into ARDS management. We've covered a lot of ground, from the specifics of neuromuscular blockade to the essentials of supportive care.
It's been a lot to take in, but I already feel more prepared to manage these challenging patients. Can't wait to hear what you've gotten so for us in the final part of this deep dive. Welcome back to the final part of our deep dive into ARDS management. Wow, we've covered a lot of ground, so much to think about.
It really is a complex condition, but I think we've done a good job pulling out those key takeaways from UpToDate.
Yeah, definitely. We've gone from the big picture stuff like conservative fluid management all the way down to those nitty-gritty details of supportive care. So as we wrap up, what are those take-home messages? Those things that clinicians can actually use to make a difference for their patients tomorrow?
For me, that conservative fluid management, it's a game changer. It's not just some theory. It's backed up by real evidence. And it challenges how we used to think about fluids. We're moving away from just giving tons of fluids and toward a more personalized approach.
It's a reminder that ARDS changes how the lungs work. And giving too much fluid can actually make things worse. Less is more sometimes.
Exactly. Another thing I'd stress is being careful with neuromuscular blockers. They can be useful in some cases, but we really got to weigh those risks and benefits. It's not a decision to take lightly.
I'm also really fascinated by those inhaled pulmonary vasodilators. It seems like such a precise way to improve oxygenation, almost like we're targeting specific areas of the lung.
I know, right? It's like they're redirecting blood flow to exactly where it needs to go, optimizing that ventilation perfusion match. It's a cool area of research, and I'm excited to see where it goes in the future.
Me too. And of course, we can't forget about the whole glucocorticoid debate in ARDS. It seems like they might have a role to play in some patients, especially if we give them early enough.
That early intervention,
Hmm.
it seems to make a big difference in ARDS. So many things hinge on catching it and treating it early.
Absolutely. And while we've talked a lot about medications and all that, we can't forget about good old-fashioned supportive care.
It's the foundation supportive care, from managing pain and sedation to preventing infections and being smart about blood transfusions. All those little things add up and can really impact a patient's recovery.
It's about remembering that every detail matters when we're taking care of these really sick patients.
I want to leave our listeners with something to think about. As we learn more and more about ARDS, what can we do both as individual clinicians and as a medical community to keep getting better at managing this condition? How can we keep improving outcomes for these patients? It's a challenge, but it's also a really exciting opportunity.
That's a great question. It reminds us that we're always learning in medicine, and that's what the deep dive is all about. To all our listeners out there, thank you for joining us on this deep dive into ARDS. We hope you found it useful and ready to put into practice. And remember, we're always here for you. If you have any questions or thoughts, just reach out. Until next time, keep diving deep. All right, so let's jump right in, shall we? Prone ventilation in adult ARDS patients. We're looking at the latest UpToDate on this, updated June 28th of this year. And, we can kind of skip those basic definitions
Yeah, let's just get to the good stuff.
right to the details. So prone ventilation, right? Like turning the patient onto their stomach. This isn't just another ventilation mode, is it? It's a whole other approach.
No, not at all. Not like tweaking settings on the ventilator. It's its own intervention entirely.
Okay, got it. So let's get into those physiologic effects. UpToDate really breaks down how prone ventilation impacts oxygenation.
Yeah, and improved oxygenation, that's what we consistently see with this. It happens through a few different mechanisms. When a patient's supine with ARDS, the heart and diaphragm, they're compressing those dorsal lung regions.
Right.
So turning them prone, it reduces that compression.
Which makes sense. And they also talk about the improved distribution of the extravascular lung water and secretions.
Right, yeah. Prone positioning helps shift that fluid and the secretions away from those dependent areas, which further improves ventilation.
And then they talk about changes in that transpulmonary pressure gradient, leading to greater expansion of ventral alveoli.
Yeah, that's an interesting point. So in the supine position, the pressure difference between ventral and dorsal lung sections, it can actually promote ventral alveolar collapse, believe it or not. But prone positioning, it reverses that, helps reopen those collapsed areas.
Okay, so we're hitting oxygenation on like multiple levels here, but it's not just about getting oxygen in the lungs, right? It's about getting it to where it needs to go. So does prone ventilation also improve VQ matching?
Absolutely. Prone positioning, it optimizes that relationship between ventilation and perfusion. And by matching those two better, we end up seeing much more efficient gas exchange.
Got it. So prone ventilation is impacting both oxygenation and EVQ matching. But the question everyone wants to know, does it actually improve patient outcomes?
So if we look at the data, most trials, especially those focused on oxygenation, they show a significant increase in PO2 with prone ventilation. I mean, we're seeing improvements that range anywhere from 15 to 70%.
Wow, 15 to 70, that's a big range. And UpToDate also mentions that some patients even continue to see improvements even after they go back to the supine position.
Right. Some studies suggest that prone ventilation actually has this kind of lasting positive effect. It's more than just those immediate changes. It could be triggering this whole positive physiological cascade.
Okay, that's interesting, a cascade. That's hopeful. But what about mortality? Does prone ventilation actually reduce mortality in ARDS patients?
Well, this is where things get really interesting. The PROSERVA trial, that was a landmark trial, and it provides some pretty compelling evidence. They looked at patients with moderate to severe ARDS, specifically those managed with low tidal volume ventilation. And the results, well, they were pretty significant. PROSERVA showed that prone ventilation significantly reduced 28-day mortality. We're talking 16% in this patient population.
16%, that's huge. But I'm guessing not every ARDS patient is going to be a candidate for prone ventilation.
You're right, there are definitely specific indications and contraindications. While the initial strategy for most ARDS patients, it should still be low tidal volume ventilation in the supine position. There are absolutely scenarios where you might consider prone ventilation earlier on.
Okay, so When are those scenarios? When should we be thinking about adding prone ventilation to the mix?
So one clear indication is when a patient isn't improving despite optimal low tidal volume ventilation in the supine position. So if their oxygenation isn't getting better, prone ventilation, that becomes a very viable option.
So if conventional ventilation isn't cutting it, prone ventilation could be that next step.
Exactly.
Okay, what other factors should we be looking at?
Well, severe ARDS is another one, and we're talking KO2 FiO2 ratio less than or equal to 150 millimole Hg with a PEEP greater than or equal to 5 centimeter H2O. These patients, they often need significant improvement in oxygenation, and prone ventilation can really be a life-saving intervention.
What about refractory hypoxemia?
Oh, absolutely. If a patient's on an FiO2 greater than or equal to 1 and they're still struggling to maintain adequate oxygen levels, prone ventilation, that might be the answer. But it's really important to remember that the Perseva trial, it focused on a very specific subset of patients, and there were some strict exclusion criteria.
Okay, so what were some of those exclusion criteria? Why wouldn't a patient with moderate to severe ARDS be included in that study?
Well, for example, patients who were unstable for less than 2 days, those with massive hemoptysis, anyone with a chest tube for pneumothorax, and a few other specific conditions, they were all excluded. So the results, they don't necessarily apply to every ARDS patient out there.
Right, that makes sense.
Hmm.
It sounds like timing also plays a role when we're considering prone ventilation.
Yes, the evidence suggests that early implementation, ideally within the first 36 hours of ARDS onset, that's associated with the best outcomes.
36 hours, okay. And how long are these prone ventilation sessions typically?
Most protocols recommend 16 to 20 consecutive hours. That allows for sufficient time to achieve those physiological benefits we were talking about earlier.
Right. UpToDate also mentions using prone ventilation as a bridge to ECMO.
Yeah, that's a possibility in specific cases, but it might be something we can save for a future deep dive. The full UpToDate resource has more information on that.
Yeah, that's a good point. Their prognosis and outcomes. We'll be focusing on a recent UpToDate overview from August 2024.
Great topic, and that overview is a really solid resource.
One of the things that really hit me from the overview was the mortality rate.
Oh, yeah.
It's still so high, even with all the progress we've made in critical care. 26 to 60%.
That's a big number.
It is. And it's actually plateaued recently.
Right.
That just really highlights the need to keep researching and critically evaluating our management strategies.
Yeah, no question. That plateau is a big concern, for sure. Really shows how complex ARDS is.
Absolutely. It makes understanding the factors contributing to mortality even more crucial. The overview mentions how the underlying cause of ARDS often determines the cause of death that first week,
Uh-huh.
but later on, it shifts.
Exactly. Later deaths are more often from multi-organ failure, not direct respiratory failure.
Which is a key difference from sepsis.
Yeah, that's a good point. With sepsis, respiratory failure often stays a primary driver of mortality even later in the course.
So we need to be really sharp about watching for and managing multi-organ dysfunction in ARDS patients.
Definitely. Especially as their hospital stay goes on.
Makes sense. Now, the overview also gets into the different predictors of mortality. It's a little daunting, honestly, to see how many factors are involved.
It's a lot to think about.
It is. It really emphasizes how important individualized, patient-centered care is.
Definitely. Every patient's different. There's no one size fits all.
Right.
But there are certain things that tend to be linked with worse outcomes.
Right.
So being aware of those can help us fine-tune our approach and have better conversations with patients and their families.
Yeah. Let's say you've got an older patient with ARDS who also has a history of liver disease, and their labs show poor gas exchange, and their PaCO2 is starting to climb.
Oh, yeah.
That's when you know it's going to be a tough fight.
Absolutely. And you see how those factors can all build on each other. Say that same patient also has diffuse alveolar damage from their lung biopsy. It's like every additional risk factor just adds another layer of complexity.
And worry.
Yeah.
It really shows just how challenging these cases can be.
It does. And we haven't even touched on treatment-related factors that can impact mortality. Fluid balance, past use of glucocorticoids, not even when we intubate, can make a big difference.
The overview specifically mentions that a positive fluid balance is linked to a higher risk of death, and prior treatment with glucocorticoids and packed red blood cell transfusions seem to have a role too.
It's a reminder that every decision we make in ARDS management has implications.
No doubt. But it's not all bad news, right? There are things we can do to help our patients.
Of course. The overview mentions that transferring a patient to an ICU with an intensivist is actually linked to lower mortality.
Interesting.
Having that specialized expertise, that dedicated team, it can make a huge difference.
So for those of us in smaller hospitals or places without dedicated intensivists, we need to be really careful about when it's time to transfer to a higher level of care.
It's a crucial thing to consider, especially with a condition as serious and unpredictable as ARDS. We've got to make sure our patients have the resources and expertise they need to have the best chance at a good outcome.
And it's not just about the big things like transfers and intensivists.
Yeah.
Even the specific settings we use on the ventilator can affect things,
Hmm.
according to the overview.
It really shows that every detail matters in ARDS management. We need to be meticulous, deliberate in our approach.
Right. Finding that sweet spot between supporting them and not causing more lung injury.
Exactly.
This has been a really thought-provoking discussion, but a little heavy, to be honest. And I feel like we've only just scratched the surface.
We have, and we've been focusing on mortality, but it's just as important to think about the long-term issues survivors face.
Right. Their journey doesn't end when they leave the ICU.
It's like ARDS doesn't stop at the acute phase. It can have a lasting impact on survivors.
It's true. The UpToDate overview really highlights the morbidity associated with ARDS, something we as medical professionals have to be very aware of.
Absolutely. We can't just focus on getting them through that initial crisis. We need to be ready to support them through the recovery process, which can be a long road.
A long and challenging road.
Yeah.
And often leads to post-intensive care syndrome, right? PICS.
Exactly. And the symptoms of PICS in ARDS survivors, they're similar to what we see in survivors of other critical illnesses, affecting cognitive, psychological, and physical function.
It's a lot to deal with. What does cognitive dysfunction look like in this context?
Well, it can vary quite a bit. Some survivors might have subtle problems with memory or concentrating. They might have trouble multitasking or making decisions quickly. Others might have bigger issues with executive function, like planning, organizing, problem solving.
Wow. What leads to that cognitive decline? The overview mentions a few possibilities.
Probably a few things together. The long periods of hypoxia these patients experience can actually damage brain cells directly.
Makes sense.
And then you add in the systemic inflammatory response.
Right.
It can really lead to widespread neuronal injury.
And we can't forget about the meds we use to manage ARDS. Some of them have neurological side effects.
That's true. It's always a balancing act, right?
It is.
Treating the immediate problem while trying to minimize the potential for long-term harm. And this cognitive dysfunction can have a huge impact, affecting everything from their ability to manage their own health care to whether they can go back to work or school.
We need to be proactive about looking for cognitive impairment and getting these patients the right resources, like cognitive rehab.
100%. Early intervention is key.
Along with the cognitive challenges, we also see a lot of psychological dysfunction in ARDS survivors. The overview mentions things like depression, anxiety, PTSD.
I mean, it makes sense. They've been through something incredibly scary, often facing death. That's going to leave a mark.
No doubt. And the physical limitations they deal with can make those psychological issues even worse.
Absolutely. Imagine dealing with constant muscle weakness, fatigue, shortness of breath, on top of the trauma of what you've been through.
It's a lot to handle. What specific physical limitations are most common?
Muscle weakness and fatigue are really, really common, even years after they've recovered from the acute phase of ARDS.
Wow.
Patients might get exhausted just from doing everyday things, walking upstairs, carrying groceries.
It must be frustrating.
Yeah.
And I'm guessing there are a few things that contribute to this.
Right. Prolonged bed rest during their illness can lead to pretty significant muscle atrophy. The systemic inflammation can actually damage muscle tissue.
Ah, right.
And then there's the impact of the lung damage. Many survivors have shortness of breath, reduced exercise capacity.
It's like a vicious cycle. The physical limitations contribute to feeling isolated and depressed,
It is.
which then makes them less motivated and less able to do the things that would actually help them get stronger.
Yeah, you're right. It's a complex interplay of physical and psychological factors.
We need to take a holistic approach for sure. And we can't forget about the long-term impact on lung function. The overview says up to half of survivors have persistent abnormalities on those pulmonary function tests.
A reminder that the inflammation from ARDS can cause permanent changes in the lungs.
And these can last for years, right?
Yeah, they can.
What kind of abnormalities usually show up on those tests?
One of the most common is a reduced diffusing capacity.
Okay.
So basically, the lungs aren't as efficient at getting oxygen into the bloodstream. That can lead to feeling short of breath, especially during exercise. Makes it tough for them to get back to their old activity level.
So even though they've survived the acute phase of ARDS, the damage to their lungs is still affecting their lives in major ways.
Absolutely. Some patients also develop restrictive lung disease where the lungs become stiff,
Right.
which makes it even harder to breathe. And on top of those pulmonary function abnormalities, ARDS survivors are at higher risk for other serious long-term complications.
Like what?
Pulmonary fibrosis.
Scarring and thickening of the lung tissue.
Right. It can lead to progressive shortness of breath and eventually respiratory failure.
That's scary.
It is. There's also an increased risk of pulmonary hypertension, high blood pressure in the arteries of the lungs. That puts a strain on the heart, and down the line, it can lead to heart failure.
So the long-term implications of ARDS are pretty extensive. Damage to the lungs plus all these other potential complications.
Right. It really underscores the need to keep monitoring and managing these patients, even after they've recovered from that initial episode. We need to be watching for these complications and step in early if we see them.
Are there any factors that seem to influence the long-term outcomes? I know the overview mentioned a few.
One of the biggest is the severity of that initial ARDS episode. Patients with more severe lung injury are more likely to have a tougher time recovering, and they're more at risk for long-term complications.
So early recognition and aggressive treatment are crucial, not just for survival, but for a good long-term outcome too.
I completely agree. And how long they're on mechanical ventilation matters too. Longer ventilation times mean a higher risk of complications and a slower recovery overall.
Right. It's like their body has gone through a war, and the longer that war goes on, the more damage is done.
That's a good way to put it. And of course, the patient's overall health before they got sick plays a role. People with pre-existing conditions like heart disease, diabetes, chronic lung disease, they don't tend to do as well as otherwise healthy patients.
So we have to think about the whole patient, the individual circumstances, their medical history,
Absolutely.
when we assess their risk and prognosis.
It all feeds into how we manage each case.
Mhm.
We need to personalize our approach to meet their specific needs and challenges.
So it sounds like there are a lot of potential challenges. But there is hope, right? The overview doesn't make it sound like everything is bleak for ARDS survivors.
Definitely. Plenty of ARDS survivors go on to live full lives. But we have to be realistic. Recovery can be long and difficult. There will be ups and downs. But the important thing is to support them through the whole process, not just the acute phase.
Exactly. And to empower them to be active in their own recovery, to give them the tools and resources they need to handle the challenges ahead.
That's the goal.
So what can we do as medical professionals to make recovery easier and support these patients over the long term? What concrete steps can we take?
Well, pulmonary rehabilitation is a big one.
Okay.
It's a program that typically includes exercise, breathing exercises, and education on managing symptoms and coping with the emotional impact of the illness.
Sounds like a good way to address both the physical and psychological aspects of recovery.
It is. Studies have shown that it can really improve lung function, exercise capacity, and quality of life for ARD survivors.
That's great to hear. What about nutritional support? I know the overview mentions it.
It's crucial. A lot of ARDS survivors lose weight and muscle mass during their illness, so getting enough calories and protein is essential. It helps them rebuild their strength and stamina.
We've got to be on top of things like calorie counts, protein supplements, maybe even bringing in a registered dietitian.
For sure. And we can't forget about the psychological support. We talked about the emotional and mental health challenges that can come up after ARDS. Addressing those is so important for their well-being and their recovery.
So it sounds like it takes a real team effort to provide the best possible care.
It really does. Doctors, nurses, respiratory therapists, physical therapists, occupational therapists, psychologists, social workers, everyone needs to work together, communicate well, and share their expertise.
It's about comprehensive, patient-centered care. And as medical professionals, we need to be advocates for our patients.
100%. We need to educate our colleagues, administrators, even the public about the long-term problems ARDS survivors face and advocate for policies and resources that help them recover.
It's about raising awareness, fighting stigma, and making sure these individuals have access to the care and support they deserve.
Exactly. And we need to keep pushing for research to develop better treatments for ARDS. The goal is to reduce mortality and improve long-term outcomes for all ARDS patients.
We've covered a lot today. The tough realities of ARDS mortality, the complex challenges of long-term recovery.
We have. But in the midst of all that, there's hope. We see stories of resilience, and there's a growing understanding of how we can support these patients on their road back to health.
Welcome back to the deep dive. We spent the last two segments really digging into the long-term effects of ARDS, mortality rates, the challenges survivors face. But there's one more thing we need to talk about, something that has a huge impact on survivors trying to rebuild their lives.
Returning to work.
Exactly.
Yeah.
The UpToDate overview points out that it often takes ARDS survivors a long time to get back to work.
Yeah.
Many are out for 2 years or even longer. 2 years.
It's a long time.
It is. What contributes to them being out of work for so long?
It's a mix of things. Often it starts with those lingering physical problems we talked about before. Muscle weakness, fatigue, shortness of breath. That can make even desk jobs really hard. Imagine trying to focus when you can barely catch your breath or you're exhausted all the time.
It must be so frustrating.
It is. And then there's the cognitive side of things, too. Focusing at work is tough enough as it is.
Right.
But when you're dealing with memory issues, trouble concentrating, difficulty making decisions,
It makes it that much harder.
it does. And we can't forget about the mental and emotional burden. Anxiety, depression, PTSD,
Right.
those can make even the thought of going back to work really scary,
Yeah.
especially if it's a high-pressure job.
So it's not just about physically being able to do the work. It's about mental clarity, being emotionally ready, and having the confidence to handle everything that comes with the job.
You got it. And there are often financial barriers, too. A lot of ARDS survivors use up all their savings during their illness and recovery. And they might face discrimination from employers who are worried about hiring someone with a history of serious health problems.
It's a lot to overcome. What can we do to help our patients through this tough transition? What are some practical steps?
Well, first, we need to acknowledge that this is a complicated issue. There's no magic solution that works for everyone.
Right. Everyone's different.
Every patient's journey back to work is unique. We have to individualize our approach, really listen to their concerns and work with them to create a plan that addresses their specific needs and goals.
So really, it's about understanding their individual challenges and what they want to achieve.
Exactly. And early, comprehensive rehabilitation is key. We need to tackle those physical, cognitive, and psychological impairments as soon as possible. That gives them the best chance of going back to work successfully.
We need the whole team involved. Physical therapy, occupational therapy, speech therapy, psychology, social work. Everyone has a role to play.
Absolutely. Getting the patient back to their full strength, helping them regain their function and their emotional well-being.
And we have to talk to employers, make sure they understand the challenges ARDS survivors face, and advocate for accommodations to make that transition back to work smoother.
It's so important. We might be talking about modified schedules, a lighter workload, or assistive devices that can help them do their job.
And sometimes, if they can't do their old job anymore because of limitations,
Right.
vocational retraining might be necessary.
It's about thinking outside the box,
Yeah.
finding solutions that allow them to engage in meaningful work. And probably one of the most important things we can offer is hope and encouragement.
Yeah.
ARDS recovery is a marathon, not a sprint. There will be bumps in the road, but we have to remind them they're not alone, and that with the right support, they can get their lives back, both personally and professionally.
That's a great message. Any last thoughts for our listeners who might be ARDS survivors themselves or who know someone who is?
Don't give up. Talk to your doctors. Find a support group. Look into the resources that are out there. Recovery is possible, and there are people who want to help you through it.
Thanks for joining us for this deep dive into ARDS, prognosis, and outcomes. We've covered a lot of difficult topics, but hopefully you've learned something valuable that you can use to provide compassionate and effective care to your patients. And to all the ARDS survivors out there, we see you, we're here for you, and we believe in your strength.